ready for a round table, and we would like to introduce Cicero Torres Silva, who will be the moderator of the round table. Dr. Silva is an associate professor in the Department of Radiology and Biomedical Imaging at Yale School of Medicine. Cicero?
Thank you, and now I know that's the leave here on time. Thanks everybody for being here. It's like a marathon, right? But it's a beautiful marathon. I think we're all learning a lot. So I will invite the presenters to be here with us at the table, Dr. Koenig, Dr. Moreira-Almeida, Dr. Schleich, Dr. Mercier. Please sit with us here. And we have some questions for all of them. And if we have time, we can also have, perhaps we won't have time. We could have each asking each other's question too. But we'll start with one question that came to Dr. Koenig, which is, recently there was a scientific research paper on intercessory prayer with negative results, meaning the patients who were prayed to died. And you had a comment on the interpretation of that result. So would you elaborate on that?
Who?
You.
Me? Okay.
Yes.
Okay, so this was a very interesting, published in the American Heart Journal. It was a double-blinded intercessory prayer study, so people who, it actually was not entirely double-blinded. Half of the group were told that they would be prayed for. So half of the group was not prayed for, half of the group was prayed for, and half of that group that was prayed for were, okay? So the findings of the study were that the group that was being prayed for and was told that they were being prayed for did worse. So imagine this, because this is probably what happened. You're having open heart surgery. In other words, they're going to, the next day, they're going to cut open your chest, take your heart out, and start sewing things into your heart. This is a huge surgery, potentially fatal. And before you go in, the day before, a person in a white suit, white doctor's coat comes up and says, oh, would you like to be in the study? And then you say, yes, okay. I just want you to know that you are going to be one of those prayed for. Now, how would you feel about that? You would feel like, uh-oh, why am I one of the ones being prayed for? You don't understand the research methodology. All you know is that you, for some reason, were selected to be prayed for. So you think, boy, my condition must be a lot worse than everybody else's, right? So you know what was worse off in those patients? It was atrial fibrillation. It's caused by a surge of adrenaline from being anxious over being told, thinking that they had a worse condition and were going to have a worse outcome. So it's completely explainable why those who were being prayed for and were told they were being prayed for did worse, because of that response to being told that they were being prayed for.
I have a question on that. Who did second best, or who did second worst? Who was in the middle? Was it the ones that weren't prayed for, or the ones that were prayed for that didn't know?
You know, I can't exactly remember.
There was no difference. There was no difference, actually. The intercessory prayer studies have provided mixed results, actually. And since this study, no other large study has been conducted, at least to my knowledge. And the results have been mixed. And the other groups, they had no difference.
Dr. Mercier, you were telling us about symptoms being just messages.
Yes.
And you do acupuncture. And at the same time, you're saying that, you need to understand what that message wants to tell you.
Yes.
So would there be a role for, hey, let's not treat and just listen to the messages?
Yeah, it's a very interesting situation where in many circumstances, the symptom is a direct result of lifestyle problems. The person is not eating well, the person is not exercising, there are emotional stresses and issues that the patient is not taken care of. And so I think that is the primary focus of my work. And so if a person is not taking care of those things in their lives, then merely focusing on the symptom may not produce a sustainable result. So it's really not so much do we treat the symptom or not, it's really making sure that the patient really understands the nature and the role of the symptom in their lives, at which point we can do massage, acupuncture, anything to provide temporary improvement of the symptom, just as long as the understanding is there of what we really are doing strategically.
Mm-hmm. Dr. Schleich, you were giving us that example where the CPSO in Ontario, the licensing body, was reprehending that doctor for asking them to get a diary of their diet, right? And then you were moving us into the Sloan Hospital where they were using music, such an opposition to that. So is there a way, or do you think that those licensing bodies are also starting to embrace this, or how do we make them embrace?
What's occurring is that the licensing bodies, those who oversee not only entry to practice but sustained practice, are changing. The membership is changing, and the docs who are populating those groups are more aware. It's certainly true in Ontario. For example, in Ontario in 1962, the last medical doctor who had been a homeopathic professional passed away, and he in this case, that individual was not replaced. By that I don't mean they didn't replace the position. They didn't replace the position with somebody who had experience and belief in homeopathy. And so there are an increasing number of those members of the oversight bodies who are more aware of what they're calling integrative modalities, integrative medical systems. So the Sloan Kettering example was very exciting because clearly those who are providing the services, designing the services, financing the services, saw the benefit to the patient and the financial possibility of those kinds of services for the patient. They're called expressive arts in our world, hugely impactful in treatment for those who are under great distress, during treatment for cancer.
Thank you. Dr. Moreira-Almeida, it's such a great work that you do, leading what you do and publishing what you do in the university. Similar to that question, within an institution, how do you deal with, perhaps if they, how do you make them embrace this kind of line?
The institutional aspect.
Yes.
Well, I think
so that we can all go back and do the seminar institutions.
Well, I had a very good professor that helped me how to do this. I think if you'd like to bring it to mainstream, for example, mainstream medicine, mainstream science, we need to be very, very, very rigorous to showing the high quality evidence showing the impact. Like this, people are religious. We have good data showing that people are religious. We have good data showing that this religious involvement impacts health, and we have evidence that dealing with this can impact patients. So I think one of the most important aspects, very concerned about the quality of the research, because this area, but in many other also, we have people that do good job and people does not that good job. So we need to be careful about this. I think the other aspect also is showing that we are not in opposition with the knowledge, scientific knowledge. On the opposite, we are just trying to move it forward. We are not denying the importance of medication, not denying the importance of established knowledge. We are just saying that it's incomplete. We need to do more. We need to expand. Talking about a truly biopsychosocial spiritual approach, seeing the person as a whole. And also in the guided institutional aspects, I think also there are many people, powerful people in any institution that usually they have interest in these subjects, but they are afraid to say openly about this. But very often they can help us behind the curtains. They can help us provide a lot of facilitation in institutional aspects. So this is also very important to have good allies. And many people are really interested. They would like that these things move forward, but they are afraid to expose themselves. But they can provide us a lot of support.
Thank you. Dr. Schleich, and I'm sorry, am I pronouncing it right?
Not bad.
Schleich. So we know what needs to change to improve healthcare delivery, but how do we overcome the power of the AMA, the pharma industries, and their lobbies?
Okay, let's see, it's 20 after 6. It's in some ways, that's my life work, although not stated as defeating the AMA's hegemony. When one understands how health professions take shape in civil society, how they demarcate territory, are able to say this is what we do and you can't do this, or this is a controlled act, or this is a protected title. Once one understands the mechanisms for that, you simply reproduce the mechanisms, reproduce the same conditions. For example, in the naturopathic profession, with which I've been affiliated for many years, our accreditors are getting their authority from the very same place as the allopathic or biomedicine accreditors. For example, respect for the role, function, purpose, and the going forwardness, thank you for that phrase, of research is part of our mandate and part of what we commit to. For example, the training structures for our doctors imitate professional training models for all professions. You may be familiar with the work of Donald Schoen. His seminal book on this matter is 1987 called The Reflective Practitioner. I think it's called The Reflective Practitioner. And what he does in that analysis is to take a look at the structure of professional preparation, how one is prepared formally for entry into a profession. Mm-hmm. And the naturopathic profession, Chinese medicine profession, the nutrition professions, and the integrated mental health profession folks we prepare follow exactly the same model. So it's learning from those models that assure safety and quality, and learning from those models that also encourage continuous growth. Over time, therefore, one can build a profession that has a collegial, interprofessional nature to it. Our relationships with the allopathic professionals in Oregon are wonderful with individuals. The American Medical Association and its state counterparts are not the same critters. They are really marking out turf economically and socially. The social closure nature of professional formation is where heads, oh dear, you're going to get the same pay per hour as we are. It's more like, what? You're going to have the same status we have? And the answer is yes, but you have to earn it. So over time, one can, in fact, create a family, if you will. Family's probably too touchy-feely. It's more like a community of professionals who work together with different, not only points of view, but different contributions. One danger, and I'll be quiet, I know it's a long answer, what one has to do is not to be assimilated by the dominant group. And that assimilation is subtle because even the naturopathic profession has tried to imitate the biomedicine medical doctor profession in some of its attributions. For example, I wrote an article recently about something called signifiers. And it drives me crazy to see naturopathic doctors in their professional pictures in white coats with stethoscopes. Now, that's all right because naturopathic doctors use stethoscopes, but those are signifiers from a different profession, and they're just signals to the community that, oh, we are of that status, you see. So it's when the professions who are heterodox master the clinical skills that make them different and offer them successfully in a community that the professions are more secure. The trouble is that professions can get assimilated easily by the dominant profession because you know that old adage, you become what you fight? I mean, look, if you'd seen me in I had hair down to my shoulders and I had bell bottom. Look at me, I look like I'm what we used to call the man back in those days. Did I become what I fought? No, what I did is to try to prepare for a career to make changes in civil society that I thought were positive, which is what we talked about back in those days. Are you as old as I am? Okay.
Almost.
Did you? So you may recall we had those kinds of visions and so on. So I'm sorry if that's a really rambling answer, but I'm optimistic that the natural medicine professions can take their place, but it's not an easy battle. In the United States, for example, the Southeast is a very different territory for that kind of growth than, say, the Northeast. The largest jurisdiction of naturopathic physicians in the world is in the Great Lakes. And everyone thinks it's on the West Coast. Now, how did that happen? And the answer is gradually schools, clinics, licensing by state authorities, and the welcoming of services by those professionals in federally qualified health centers and elsewhere incrementally created the collegiality that makes all the difference. The tipping point is collegial connection. And we have more and more of that all the time. It's easy to say, oh, those allopaths, you know, they do. They just talk to you for 7 minutes and give you a pill. That is so not true. There's still some, I'm sure, who do, but I have a feeling there are a few naturopaths out there that do the same, except it might be a supplement.
Thank you. Dr. Mercier, is there a correlation between the acupuncture meridians and neurotransmitters or neurons outside the brain?
Between the acupuncture.
That's what I believe.
Okay, yes,
Yeah.
yes. Yes, no, there's very solid research on that. It's a study where they will induce analgesia in rats, laboratory rats. They put a point, I don't know where, in their near their knee, whatever the equivalent of knee is in their hand, and induce an analgesia. And then they will reduce the analgesia or actually eliminate it by injecting naloxone, which is a narcotic nullifier. And this study has been done many, many times, and it's fairly conclusive that there is an opioid production, endorphins, with acupuncture. You know, from my personal experience, as I look at the range of human emotions, positive human emotions that can be triggered by it, I have no doubt that there's much, much more. So all the neurotransmitters such as dopamine and serotonin, GABA, and so on, I think are being produced. I don't know what the research is on that, but there are many occasions where a patient will, as soon as the needles are inserted, go into a state of near bliss, sort of like we feel after a massage. And so there has to be a pretty strong neurochemical mix at that point, but I can't be more specific other than the research on endorphins.
Thank you. Dr. Koenig, today a lot was discussed about the importance of spirituality in medicine. What would be practical approaches of assessment and counseling that you would suggest that could be used in primary care?
What kinds of approaches to assessment and counseling could be used in primary?
In primary care.
Yeah, like for primary care doctors, I would suspect, or?
I would think so. Whoever asked the question, yeah, for primary care doctors.
Yeah, I think the most, that is the one thing that you can do that can be fairly short. And it's really the core of integrating spirituality into patient care, into primary care, is this spiritual history that communicates to the patient that it's okay to talk about this, and that this is important, and it's supportive in many respects. Just doing the spiritual history is supportive in itself for the patient's ability to cope, to use their faith in coping, because if the doctor asks about it, then it must be important, and it affirms that. So the spiritual is a very powerful actual intervention by itself, simply asking the questions that you wouldn't think that would be the case, but it really is. And that's really all you really have time to do. I mean, you can do, depending on the patient, depending on yourself, depending on how much time you can do other things. You can pray with the patient if they ask you to pray. It can be a very short prayer. If you feel uncomfortable with it, you can have the patient say the prayer and simply agree with them. So praying with the patient, saying that you're praying for them. And that doesn't require really any time. You know, it requires when you pray, you have to do it. You can't just say it and not do it. In psychiatry, I found have changed my attitude towards my patients, if nothing else. And you know, every time I say, you know, I am praying for you, and you know, I'm by name. I'm not just saying, you know, okay, all my patients, you know, God help them, but so and so help so and so, and you know, they know that I'm doing that, and that really makes a difference, I think, for them. They've told me that, and it reinforces, you know, their faith, which is sometimes all they have when they're struggling with some of these horrific conditions that we treat them for.
Dr. Moreira-Almeida, you told us about some patients that have a way of coping that is religious coping that is negative. As you know, God will take care of this. How we as providers can deal with that? What are some hints you would give us?
I think this is one of the most challenging aspects, because when the patient has some positive force stimulate them to go further or to resume some previous positive religious coping strategy that they are not using anymore. But when they have negative religious coping, when they have, for example, some negative religious cognitive framework about something, when they have been told in their religious community something, for example, to stop the treatment and things like that, it's sometimes because there is an ethical point, because it raises some ethical issues when we need, for example, to challenge the religious belief of patients who we don't have the right to try to convert or to change the religious perspective of patients. So some strategies that can be used and that are not problematic in the ethical perspective. For example, first, punishing me, God will never forgive me for something that I did and things like that. And because sometimes the patient has this perspective, but it's not exactly the perspective of their own religion. So if the patient is Christian, for example, I could say, okay, and how Jesus dealt with people who did bad stuff? How Jesus did with the adulterous woman? How Jesus did with the prodigal son? Things like that. So we can take from their own religious background and help them to think about how their own religious background deal in different perspective with their own point. So this is one strategy. The second strategy, we could ask the patient also to talk to their own religious leader. Sometimes the religious leader will help them to deal in a better way with their negative religious coping. But if the religious leader is the problem, if he is the problem, I have two approaches. One approach that usually has been very useful also. For example, the religious leader is stimulating the patient to stop the treatment. I could ask the patient if I could have a contact with the religious leader. Could I call him or her? And if the patient allows, I would call. And of course, not call to say, oh, what are you doing? You cannot do this. No, I say, oh, I have a patient from your religious community. And this religious community is very important to the patient. And I'd like to help to work with you in a collaborative way in helping to restore fully this person. And when we have this approach, not in a confrontational way, but in a collaborative way, usually they tend to be collaborative. The other perspective also, the other possibilities to help the patient in seeking different perspectives in their own religious tradition. Because we know no religious tradition is monolithic, has only one perspective. If the patient is Catholic, is Spiritist, Buddhist, or whatever, there are different approaches to the same topic many times. So have you tried to see different perspectives, other leaders in your own tradition that perhaps see in a different perspective the same problem? So this also has been very helpful. So this is just some strategies that can be helpful.
This one goes for either Dr. Koenig or Dr. Schleich. It says, although it may be challenging to apply integrative or holistic medicine into practice at a fast-paced acute care or medical surgical unit, the need for this type of care not only for patients, but for healthcare providers as well. So how can a healthcare provider educate efficiently with senior leadership for support on stress prevention and management intervention for staff first, and then if that is successful, to provide it to patients too?
Okay, so that's true. That's true that taking a spiritual history, I'm not sure it's been shown in research. See, this is an area, though, that needs to be studied, is that taking a spiritual history, integrating spirituality in patient care is good for healthcare providers in terms of their satisfaction with their work. I believe that is true, but I can't think of a research study at the moment that has shown that that is true. So it's going to depend on, on some argument that is in the absence of research. By simply mentioning, the high burnout rate, extremely expensive for hospitals and various healthcare organizations. When somebody burns out, a lot of money has been spent in training and in recruiting that individual, and if you lose them, then that costs a lot for your system, because then you got to hire somebody else You have to recruit somebody else from the burnout. So right now, the only thing, to your administrator, you can say, there's a high rate of burnout. What is the burnout here in the hospital? Are you concerned about that? Well, there is some healthcare professionals are saying that when doctors address these issues, when they take the time to address these issues, a greater reward from their practice of medicine. They get more sense of meaning and purpose from what they're doing because they're providing whole person care that patients really appreciate. And that positive feedback makes the practice more rewarding despite all the other negative things about practicing medicine, nursing, and and other healthcare, counseling, etc. So it's tough without evidence. That's why it'd be sure nice, because we're pretty dark. You think there's some evidence?
Similar to what you're saying, Fur Curling has a very nice study showing that physicians who see the profession, the medicine, as a kind of spiritual vocation, they had higher lower burnout. Really? Lower burnout. Yeah, the sense of calling, the sense of spiritual calling, because as we know, for many of us, the choosing was spiritually motivated, partially at least. So if we see our profession in some sense a spiritual calling, it has, so there is data, a national survey in the US for fur curling showing that's correlated with lower burnout. But there is only one study that I'm aware of. I don't know if there are others.
I'd like to add a comment. We need an Institute of Spirituality and Medicine in every medical school. I mean by that so that in the clerkship portion, perhaps somewhere along the continuum of training, the modeling of what we call at our place, physician heal thyself or healthy self, shows up as desirable. I have been really lucky to have visited nearly 1,000 doctors' offices in my time and roles I've had. And the most embody that kind of balance. And there are best practices that we don't have time to enumerate here, but they include such things as a team approach to care. They include such things as an education program for patients, particularly families. What I also see in those visits to docs' offices is that the notion of integration and prevention show up really as just manifestations of the same madness, which is, just rather than providing professional development for the provider about what he or she can educate, teach, train patients to do that is genuine prevention, such as nutrient density sourcing and so on. It's a very complex response because the medical docs I meet are very burdened. They're really burdened. And the naturopathic docs who are successful say, boy, how do they do it? Because of the pressure from the health maintenance organizations and the health networks that have constraints on time and so on. It's a very tough job. Now, who's the boss? Fewer and fewer medical docs who actually operate clinics. They work for others or work for groups. So who's the boss? He or she or they probably need to be challenged around long-term professional development and care providers.
For naturopathic doctors, how long is a typical appointment with them? How long does the patient stay with them? And do they also assess the emotional needs, the spiritual needs?
Indeed. We have some naturopathic doctors nearby who could attest to this. But in our case, a standard intake is about 45 minutes to 50 minutes in the first instance, sometimes longer. Chinese medicine's a little longer. Half an hour. It's very rare for an 8 connection with patients. So you might say, how on earth do you afford that? Well, part of the answer is that a lot of naturopathic doctors are forced into cash practices. And that, of course, changes who they're able to see. Another is that they're trained to find out everything they can about a patient as early as possible. And it's instinctive to them, almost intuitive to them to behave that way. It also means that they earn less money.
Although thankfully, I think that there are insurance companies that are also accepting naturopathic doctors, right? I mean, I don't know if thankfully or unthankfully, but that is already happening, right?
It is indeed, and that's improving in many places. And I can cite examples, specific examples of quite successful naturopathic physicians. What's occurring is that the naturopathic physicians and Chinese medicine professionals are showing up in integrative clinics or multidiscipline clinics as employees. That's a phenomenon that's probably ought to be studied, and they're being paid very well. An example, if I may, to illustrate, in Portland, Oregon area, there's a network that has a couple of dozen urgent care centers. And 7 or 8 years ago, there wasn't a naturopath to be seen anywhere in those centers. Now, there are several dozen. And the reason is that the owners were persuaded that effective patient care could also be profitable patient care. And the naturopathic approach is very popular. And it's examples of how you can monetize that patient flow are existing more and more, such as in the Zoom Care network in Oregon. There are similar networks which are showing up interestingly enough, in the Midwest. And here's a very interesting phenomenon, if I can call that a phenomenon. Texas, which does not license naturopathic doctors, has the state of Texas has a growing interest in naturopathic doctors as providers, particularly about nutrition and lifestyle. And they're showing up in the centers of integrative physicians and their managers because of their particular skill and the worry of the health authorities in Texas about the data showing, the morbidity and issues connected to diet and diabetes mellitus and so on. So there's an economic incentive to draw people into the equation who can provide those services that the medical docs find out. It's very hard for them to charge for that with the, the codes, the billing codes. How do you code for a 1-hour visit around the whole family's habits of buying food and preparing it? How do you do that, for example? So what we have is a training system called Food is Medicine Every Day, and FAME, or FAME as some of them call it, which is exactly about that: sourcing food, preparing food, and eating food, is not gobbling it up. And the impact is significant. We had a project called Ending Childhood Obesity, funded by not a health authority, but by a grain company called Bob's Red Mill. And the changes in habit across a year, there were 82 families involved, were remarkable. Proper, I just mean elongated with some good controls, would have probably indicated through testing, just what an impact such an approach to health would have in a population over the long period of time. What's sad is that many of those folks in that program were underserved populations who wouldn't have access to whole foods, kinds of food sourcing. And so, and I'll give one other example, if I may. I got lots of them. Coffee Creek Penitentiary in Oregon. Coffee Creek. Adults in custody, females. They go in at a certain weight and invariably come out 16 to 18 to 20 pounds heavier after their incarceration. Our program has reversed that, not entirely, but significantly impacted it, because the adults in custody there, the women grow their own food, prepare their own food, and there was a wonderful collaboration with the authorities in that facility to encourage that. And that's long-term prevention, and significantly has now being imitated in 3 other penitentiaries in California.
All right, thank you very much. Now it's 10 to 7. There are a few other questions, but we're running out of time, so I'll ask that the people that we couldn't ask the questions should come to the speakers directly and talk with them later. I thank each and one of you very much for being here. And Daniel and Leticia, would you close?
Thank you.